Thanks for coming to my presentation today. It's very informal. If you have any questions, be sure and ask. It's not a problem. You can stop me whenever you're ready. I printed out this PowerPoint for you because we don't usually have good computers up here, and I didn't want anything to mess up while you were looking at it. The course that I was in this semester was that clinical praxis, and so I didn't know what praxis meant. So I looked it up. Combination of theory and practice in the workplace, and I put that on the first page of your PowerPoint. And that's exactly what this is. I had to come up with 3 objectives, and I chose diabetic patients to focus on. And then I had to find some theories that would go with that for my objectives. So my first objective, as you see on that first page, was researching the verbiage related to patients who have been unable to follow their treatment plan. So you know how we have those diabetic patients that just don't seem to keep with it. And so a lot of times we'll call them non-compliant. Well, not really the best words to use, because what do you think of when you hear non-compliant? Not
Just don't do what you're told.
difficult. Right. Not a positive idea, is it? And so part of my research was what other words we could be using that would give a little more positive look at it. The other objective was what barriers are preventing them from following their treatment plan. You know that everyone has different barriers. It's individual for a lot of people. Some people it's money. I'm sure you can think of many barriers that you found that patients have. And my third one was what holistic methods could be used to help patients follow their treatment plan. So something that maybe isn't a prescription that we could use to help patients follow their plan and have better outcomes. So on the verbiage page, we've already talked about noncompliance. So a couple of other words that I found when I did my research was adherence and concordance. And so what really seems to be the way people want to talk about it now is the adherence, to be adherent or non-adherent with their treatment plan. So on the next page you see compliance is that the patient's behavior coincides with medical advice. Concordance is more like a negotiation where we sit down and talk to the patient about what's going to work for you. If we tell someone that we want them to walk 5 miles a day and they have foot pain, well then that's not going to work. So we have to have a little negotiation there with the treatment plan on what they're going to be able to follow. Then we have to remember to respect the patient's agenda too. They have their own agenda just as we do. And adherence, which I said is really what I'm finding in the literature is the most common verbiage to use, is really about the decision to accept, reject, or modify their treatment plan. And that's the patient's decision. Like I said, it's a negotiation that we have with them, but it's really their decision on what we want them to do or what we think they need to do and what they're going to do. So the next page I talked about barriers. The cost seems to be a big one, and I am working on a notebook that will have in it the different new medications and the coupons and what they're good for. And I'm going to go online and look for some patient assistance programs and try to make a notebook so that we'll have all that in one place. So it'll be a little bit easier for us to try to help them with that. Education. Do they understand their chronic disease? Have we really talked to them about it enough that they are educated in what's going on and in what this effect is going to have for them further down the road, what kind of complications they're going to have. One of the theories that I found is locus of control. And that theory really, do people have an external or an internal locus of control? Everyone has one or the other. What do you think is under your control? And I found when I talk to a lot of patients that patients don't think their diabetes is under their control. They don't think they have the control for it. And so that's one of the theories that I've been working on. And I found this neat little thing about locus of control that I printed out for you, talking about the things that you can control, things out of my control. And when I talk to diabetic patients, they seem to put their health care as the things that are out of their control. So we need to find a way to help them bring that back into their control, to believe that they can control that. The next one is my chronic care model. That's the other theory that I worked with this semester, and that's really close to what we've been doing for chronic care management. Talking about the health systems and the organization of the health care. You know, we have a good clinical information system with our EMR system. Good decision support, the delivery system is good. That's the organization of the health care. Then on the other side is the community. Resources, policies, self-management support. When I read that and thought of community, I thought about the diabetes education, the podiatrists we send them to, their eye exams, the people in the community that help support this patient to get better outcomes. So if we have an informed, activated patient and a prepared, proactive practice team, we can get some good outcomes. But it takes all of this working together to be able to get us there. And again, the chronic care model, for patients to have positive outcomes, there must be successful interaction between all the key concepts included in that illustration. Patient-centered treatment. That's really what we have to work at. We have to remember we need to empower the patient so that they're able to take control of their chronic disease. Without them feeling that, we're not going to get anywhere if they don't feel that empowerment, that it's in their control to be able to get that done. The patient needs to be self-aware. We need to help direct their behavior changes. So when I think about that, I think of the different things that we can make up: care plans, written goals that we get with the patient to decide on what they might need to do to try to get that done so that they'll be able to follow it. I think for too long we have just told patients what we need them to do. This, and this you need to do. And then they leave the office going, well, I can't do that, or I don't want to do that, so they're not going to do it. So if we don't sit down and do that ahead of time, I think that makes it much more difficult between our communications. Method of self-awareness. Reflective journaling is something that I have tried this semester, and I've even told a couple of patients about it, and I've gotten some really positive reactions from them. The people that can't seem to believe that this is in their control, I've talked to them about writing about it. Write it down. What do you feel that you can't control? Do you feel that you can't control your diet? You know, we've had them keep food journals for a long time. Well, when you ate those 5 pieces of pie, why did you do that? Why did you feel that that was something that you needed to do? And reflect about what maybe they could have done different. And it's not something that they have to turn into us. I've told patients that this isn't something I'm going to grade you on. I'm not. It's a way for you to try to understand why you do the things you do and maybe reflect on how you might have done better. How many times do we hear, I can't exercise because my knees hurt too bad or my joints are too bad? Mm-hmm. Well, what different kinds of exercise could you do? Could you try a bicycle? Could you try some water aerobics? What else can we have people do? And I think if they would learn to reflect on the things that they can't do, then it would lead to more better outcomes where they're able to see what they're doing and maybe what else they could be doing. There's not really any way to find out if that's working or not. I thought maybe when we check A1Cs on the people I've talked to about it, I could see then if that seems to have made a difference. Do y'all have any questions? I think that was my last page. Mm-hmm. Do you think that it's something reasonable, that these are things that you could do in your practice to try to help patients? And do you feel like there's things now that you're doing along those lines? Like we have more communication than we've had?
And we have lots more material than we've ever had, as far as like those books and like how to count your carbs and different things like that you can hand out that have illustrations, and I think that make it much easier for patients to do on their own as well.
Mm-hmm. And don't you think that chronic care model with us doing that chronic case management where the person has someone to talk to, where we could keep a better eye on how their blood sugars are doing, and to have that communication open more, because I know you don't have time to call and say, well, did you read your book?
Right.
Time's the problem.
Mm-hmm. Definitely.
Anybody else? No? All right, well, thank you so much for coming. I appreciate it after this long day.